Thank you so much, Claudia. Thank you, Brian. It's a pleasure, friends, colleagues. It's a pleasure to be here, an honor to be here. And what I want to talk to you is about what we do at our... Okay. What we do at our hospital. This is the Royal London Hospital for Integrated Medicine. This is Queen Square in the centre of London. We're about 300 metres from the British Museum. Queen Square is synonymous to British doctors with neurology. The national, right here, this wall here, is the National Hospital for Neurology and Neurosurgery, the leading centre in the UK for neurology and a leading international centre. This here, on this road here, is called Great Ormond Street. For British doctors, indeed the British public, it is synonymous with paediatrics. Great Ormond Street Hospital for Children is the leading centre in the UK and a leading international centre for paediatrics. This is an interesting topic, which maybe we'll have time to talk about tomorrow with our chairman's permission. The World Health Organization has a strategy from 2014 to 2023 for what they call TNCM, traditional and complementary medicine. And what they're working on now actively is guidelines for safety of acupuncture, which is something I'll talk about a little more. So we've got a nice building, but actually being sandwiched between two larger and richer neighbours with a nice building is not always a very comfortable place to be. And nevertheless, we survive. We are part of this group, University College London Hospital's leading academic medical centre in the UK, linked to University College London, which is a leading university, top 5 university in the UK. The hospital has 7 hospitals, which include us. We're at the bottom for purely alphabetical reasons. But again, this is a mixed blessing. You may think great to be linked to a leading university, but of course they're snobs. I hate to say it, Claudia, but academics can be terrible snobs. And they're a bit dubious about us. But Claudia and indeed Gary have helped us. You've helped us probably more than you know, making headway in developing our research with UCL. So this is the main University College Hospital. We now have collaboration, integration projects with most of these centres. The Cancer Centre, which is actually based on the Sloan Kettering. Our chief executive went to New York and said, I've got to have one of them. And he duly got one. The biggest cancer centre in the UK. The Dental Hospital, the Women's Hospital, Women's and Children's, we have projects with. The Hospital for Neurology and Neurosurgery we work with on pain. So we have integration projects with most of the other hospitals in the group. And we are, although one of the smallest hospitals in the National Health Service, the most popular with its patients. This has been surveyed by, in fact, by 2 independent groups. Both of, well, actually, one said we were the second most popular. Out of about 5,000 hospitals in the National Health Service, we were the second. The other said we were the first. This is the website, and this is the comments of patients. We are very popular with our patients, which is just as well because somebody would have abolished us by now if we weren't. And this is why people come to us. Interesting, I think, here, actually the biggest single reason is they have adverse effects or they are worried about adverse effects. It makes up 40% of reasons. This is perhaps not surprising, nor this, but this is actually quite revealing. It's about adverse effects of treatment are a major driver for people to come to us. We have a proud record of innovation. I hate to tell you, but I was actually a very, very, very junior doctor when we introduced the first acupuncture, so I'm really giving myself away here, but the first NHS acupuncture service in the National Health Service. People thought we were mad Maoists at the time, but now it is officially recommended by official bodies, which I'll show you in a minute. A number of other things we've done, and we do a whole lot of things, and we'll talk about some of these. This is, for instance, this service runs with the dental hospital. We are in our group, the Eastman Dental Hospital, leading dental hospital in the UK. We have an integrated facial pain service. So just our services, we do a lot of acupuncture, including high volume group clinics, I'll show you, and mostly Western style, some traditional complementary medicine, a lot of other services, musculoskeletal medicine. My colleague, Jonathan Hersey, is here. He's the lead of the musculoskeletal service, and that is our biggest single service. I run the rheumatology service. But life is tough. We live in austere times, and you have to understand how our system works. The National Health Service is state-funded. It is the Tea Party and the Tea Party's worst nightmare, actually. But But it is not a monolithic service. The money does come from the government, but the money goes down to the bottom. The money goes to what they call clinical commissioning groups. These are bodies who are responsible for, on average, about 250,000 patients, and they have the job then to buy services for those patients from providers. So we are providers, and we have to negotiate with the commissioners, the commissioning groups, to buy our services. So we divide our services into three categories. Category 1, this is based on authoritative guidelines and now is well over 60%. So this is safe. They automatically approve treatment for these things. Also for complementary cancer care. This is the difficult bit, paltry. It's not, I think it's not an accident that it's very like police. It is policed. Stands for procedures of limited clinical effectiveness, and they need individual approval. So that is quite tough for us. And this is to show, so these are the category 1, these are the authoritative guidelines which they will automatically approve. And as you can see, the majority of them are for pain. Chronic low back pain, facial pain, fibromyalgia, group acupuncture for headache, group acupuncture for knees, irritable bowel, and a recent one, pediatric chronic pain. We have also these which are not primarily pain. And then for other, so this is category 3. So this is where there is not automatic approval. We have to we have to demonstrate a need. And I developed this. This is particularly for musculoskeletal. We have different ones for general medicine, for women's. I developed these on the basis of the map of medicine. I don't know if anybody's familiar with the map of medicine. It's quite a useful resource. It's online. And what is useful about it is it shows you for a particular condition what are the primary care treatments and what are the secondary care treatments. So basically here we say, well, the patient should have tried and exhausted all primary care treatments and at least the main secondary care treatments. And if those have not worked, then we can at least argue that it should be funded. I filled in one of these yesterday. Here I wrote, on 19 different drugs. I truly had a patient who was taking 19, not tablets, drugs, about 40 tablets and a couple of inhalers. Shocking. All I wrote, 19 drugs here. And she had a BMI of 44. And she'd given up smoking. She had given up smoking, but not because of her health, because she couldn't afford it. So. But so this is, very frequently, of course, patients have not responded or have had adverse effects. So this is the justification we have to have for patients who do not fall neatly into one of those categories. So this is the guideline NICE, and this is the National Institute of Care and Health Excellence, a very powerful body in the UK. Its guidance is not legally binding, but it is very difficult for commissioners not to purchase services. So this is their guidance, which we loved when it came out. Manual therapy and acupuncture, basically. Don't do any of this, which caused great upset in the British Pain Society. They didn't like it at all, but we loved it. And we had, in fact, had a back pain service running for 15 years at this time. We had to make only the most smallest changes to make this 100% compliant. So that was good for us. So basically, it's manual therapy and acupuncture. Don't inject, and so on. This is our clinical guideline for low back pain. So the patient is referred, triaged by Jonathan or one of his colleagues, then assessed. And it's important to notice that these are vertical lines. At one time, we had crosslinks between these different areas. And the problem with that is that the patients would go down one, and then go back and go down that one, and then go back and go down that one, and would go around the loop forever. And you'd quickly get into an area of diminishing returns. If they haven't responded to, one form of treatment, they're unlikely to respond to another. And the commissioners didn't like it. They don't like paying for patients indefinitely. So we would discharge them. If the family physician wants to send them back, then of course they can do so. Group acupuncture clinics, this is very successful. We do acupuncture in a group. This is a panorama of our acupuncture room. It has 5 couches. The acupuncture is done by nurses with standardized treatments. And we have guidelines, which I'll show you in a moment. There are confidentiality issues. You can see you only have screens here. But on the whole, it works very well. The patients like it. We were worried when we introduced it that the patients wouldn't like it, wouldn't like the privacy, the lack of privacy. But actually, it seems to be in some ways better than individualized acupuncture, not just because it's more efficient, but because the patients can talk and meet and have a bit of a social occasion afterwards. So this is very successful, and we have these for several things. Safety is very important. So this is the official document of our trust on the safety of acupuncture, all duly approved. And of course, there are people who don't work in our hospital who do acupuncture. So these are formal guidelines on what you must do for the safety of acupuncture. Most of it is not rocket science, like you must use disposable needles. You must count needles in and out, a number of other issues. And there are associated guidelines, so the use of gloves with acupuncture. The answer, so we did formally review it. The answer is we don't recommend it because it offers very little protection against needle stick injuries, but does reduce dexterity. So we're against that. And we also have an acupuncture information leaflet, which has been duly read and approved by a very bureaucratic process. So these are recognized throughout our very big trust. And this is a chart we have recently developed showing basically the areas where you need to be careful not to put needles in too deep, not more than 30 millimeters. So we have a comprehensive set of guidelines on the safety of acupuncture, which are enforceable across our trust. And this is important if you want to do group acupuncture. And one of our philosophies is to get people to incorporate within their normal practice. We're working with radiotherapists, training radiotherapists to use acupuncture. So they're not highly trained. It's important that they have good guidelines on safety. This is another big area for us, irritable bowel syndrome, very prevalent condition, generally very badly treated, diagnosed by one of my colleagues, standard criteria. This is the standard instruments for measuring before and after, and triage agreement with the patient on what treatment they want. There should be a line here. So they can have homeopathy, nutraceuticals, or physician management, or CBT, a lot of dietary input too. And similarly for fibromyalgia, this is me, I'm the specialist physician, so I diagnose according to the normal category and give various treatments including homeopathy, nutraceuticals. And these solid lines represent the majority. Most patients go down, about 80% go down this route. These are for the majority, so the patients who have severe psychological problems may have individual psychiatric care. Those who do not have severe psychological problems go through this group program for 8 weeks, which includes activity, relaxation, exercise, cognitive behavior therapy, and so on. And then home exercise, graded exercise and home exercise. And these are sort of supplements. We don't use acupuncture very much for fibromyalgia because it's so generalized. And then they have to be reviewed and discharged after 6 sessions. And this is based on, it's important for us, for the commissioners to show that these are based on established guidelines. This is the European League Against Rheumatism and the British Pain Management Society. So they're based on well-established guidelines. This is group hypnotherapy, which we use for fibromyalgia and for irritable bowel syndrome. So we use a lot of group techniques. And patients on the whole like it. Sometimes not, but the majority like them. So just about dimensions of integration. For one thing, we're part of the system. We have common electronic patient records with the rest of our trust. We can look up all the blood tests very quickly. A culture of evaluation of research and the use of guidelines as far as possible. Professionalism, these are some of our pharmacists dispensing homeopathic medicine. So all our staff are highly trained professionals. So these are pharmacists with special training in homeopathy and with phytotherapy, herbal medicine. And as I say, our philosophy now is to, as far as possible, train health professionals to integrate complementary therapies in their daily practice. So we are at the moment doing a research project which involves training radiotherapists in acupuncture to deliver the acupuncture with the patients they're treating with radiotherapy, tightly integrated. In research, we're particularly interested in model validity. This means, is it good acupuncture? Is it good homeopathy? We've got some systematic reviews coming up for publication looking at the different treatments that have been used for acupuncture in cancer and cancer-related syndromes. So trying to define what is good and what is not good practice. In our radiotherapy project, we had brought together a panel of experts and drew up a standardized protocol. These are people who are not highly trained in acupuncture, they're health professionals, so they need a standard protocol. And then we have various models of integration. So there's fully integrated, that we do this, for instance, with the dental hospital for facial pain, highly prevalent condition, difficult to treat. We have unique services, for instance, for chronic fatigue syndrome, again, highly prevalent. Most doctors hate it. They don't understand it. They don't like it. But we can help them. And then co-located services within the main service. So we are present within the cancer centre, in the children's department. And then cost effectiveness. For what we call effectiveness gaps treatments. We actually did a survey of family physicians to find out which conditions they have trouble treating. We call it effectiveness gaps. So group acupuncture, group techniques particularly for that. So they're cost effective for problems which doctors have struggled with. And then collaboration with key external partners. Chronic pain, the Great Ormond Street Children's Hospital is very prestigious, leading hospital for paediatrics in the UK. And we are now developing a pain service with them, I'll show you in a moment. And of course, you can never underestimate the informal contacts. The oncologists, of course, say to their patients, you know, they don't believe in anything we do, but they send the patients because they know the patients come back, so they're much better. It's very, I don't use it, but my wife does. That's the thing they often say. So pediatric chronic pain, this is one we're in the process of developing in collaboration with who's right next door to us. Mostly acupuncture for abdominal pain, but we're in the process of developing it, and we're going to include hypnotherapy shortly. That's just to show you the pathway. So there's a robust triage system, acupuncture with a specialist practitioner. This is a highly trained acupuncturist, and reassessment and discharge. And we are going to incorporate, this is currently mostly for children with chronic abdominal pain. We are going to incorporate hypnotherapy in that in the near future. So the challenges and constraints, we have had a terrible time, you know, with Twitter and, you know, with sustained campaigns. What we find is actually on Twitter, it's very difficult. But if we have an open debate, we'll win it every time. Skepticism from colleagues, particularly older and academic. I could have said male there, but I thought I'd better not. Financial problems. And then the famous Polchi. So grommets, tattoo removal. You have to fall out really, really badly with your ex to get your tattoo removed on the NHS. It has to be, you know, they have to be threatening you with murder. But complementary medicine comes into the same category. So finally, responsive to need, looking for the areas we can help where there is not good treatments, a range of therapies, in-depth integration, as far as possible, guidelines, evidence and pathways. There is not enough, as I'm sure we will discuss tomorrow, not enough evidence. We need to develop the evidence. Patient preference and research, of course, we do badly need. So I thank you for your attention.